dyskinesias, and they're told from the patient standpoint, and they're really good. And then there's another one called Dyskinesia, a Patient Story. So I'd recommend those to you. They're 5 to 7 minutes long. And then there's one I'll show you at the end of the class today. Oh, and the impulsive behavior. So, you know, some of these drugs will increase, like the dopamine agonist will increase impulsive behavior. So they'll start gambling. They may get hypersexual. They may start spending money like they've got millions. So the impulsive behavior can be really a problem. And this person, this is also told from a patient standpoint. So it might be one you find interesting as well. Okay. So page 8. So the cardinal symptoms are listed there at the top. So bradykinesias or akinesias. So movement is really, the motor functions are really affected by this disease. Resting tremor, rigidity, postural instability. So the drugs can help with these. The drugs are divided into pharmacologic, which we're mostly going to concentrate on today, non-pharmacologic, and surgery. There's only one surgery that I'm going to mention. Did y'all talk about deep brain stimulation? Okay, then I won't spend any time on it. I've got a little section in there. But there's also, I didn't add it, but there's a really good video on YouTube of a lady who got the DBS, and it's just amazing watching her before and after. Did they show that one to you? They show one to you? Really, really impressive. You can also look at pharmacologic therapy. Really what we do is we treat the symptoms. There are some evidence that some of these drugs have some neuroprotective properties, but they will not cure the disease, and they won't keep it from progressing. So mostly what we're trying to do is keep people functional. So decision to treat, again, it's kind of like the essential tremor. It's when it starts to cause the patient enough trouble that it impairs them functionally, is when the decision to treat. So some people with mild disease will opt out of treatment. So that's good too. So when it interferes with work, daily activities, social, leisure functions, gait disturbances are really a problem in getting around safely. That is also an indication. Okay, so goals of therapy. So maintain the best quality of life we can with their motor function, preserve their ability to carry out their task of daily living. Improve mobility, minimize adverse effects, which are significant in with most of these drugs, and improve other things like their cognitive thoughts, to prevent depression, fatigue, and preserve sleep. The major classes are listed on page 9. Levodopa and dopamine agonists are the foundation. They're usually where we start because they're the most potent, and they're replacing or they're enhancing what is being lost. The Mao B Inhibitors can also be used as monotherapy early on. Anticholinergic agents can be used as monotherapy early on in younger patients where tremor is the predominant problem. Amantadine, very old drug. If you were sitting here 30, 40 years ago, it would be one of our first line because other drugs now have come into being and are more effective, and that one has very limited. And then the COMT inhibitors are similar to the MAO-B inhibitors. What they do is they were knocking out the enzymes that terminate dopamine activity. So we're just allowing the dopamine that's around to stay around longer. So general principles, levodopa, most effective, usually first line. Dopamine agonists, early on, usually, yes?
This morning, the guest lecturer said that you don't use levodopa first because they will, like especially if they're younger, because they will run out of dopamine, and so you usually save it until the disease gets worse.
Yes, that's true. So in that next section, it'll talk about dopamine agonists we'll usually use in younger people. If they are older, the guidelines say about 65 and older, start with levodopa. But you're right, in the younger patients, under 65, under 50, you'll see in other statements is start with the dopamine agonist. They will always have to go to levodopa, always. It's usually good for maybe 5 years. So that's very true. Let's see, and I've got that listed under either levodopa or dopamine agonist, younger patients, older patients. The rest of it I think I have said. So let's look over on page 10 with levodopa. Most effective. So levodopa is a precursor to dopamine. So remember, dopamine is one of the major neurotransmitters in the brain. Levodopa gets converted to dopamine, but one of the problems we run into is that a lot of that will get converted in the periphery and won't reach the brain. The levodopa also can get across the blood-brain barrier. The dopamine cannot. So that's why we use levodopa, is because we can get better brain concentrations. They stimulate D1, D2 receptors in the brain. They're deactivated by MAOB and COMT enzymes. That's why we use those inhibitors to prolong therapy. Underneath that picture, the indications for treatment are listed. So bradykinesia, slowing down, shuffling walk, shuffling gait, those are going to be helped by using either levodopa or the dopamine agonist. Levodopa, drug of choice for severe bradykinesia, especially those that threaten the person's ability to get around. Okay. Next page, formulation. So you must have talked about carbidopa and why you use it. So what's its role?
Cuts down on nausea.
Pardon?
Cuts down on nausea.
Well, it can. It can. Why else do we use carbidopa with levodopa?
That's all she told us.
It's a, huh? That's all she told you? Okay. Okay, that's true. That it does help with the nausea, which can be significant when you start therapy. But it's a peripheral decarboxylase inhibitor. So if you look at that picture, what it does is it keeps the peripheral enzymes from breaking down levodopa. It allows more of it to be able to cross into the blood-brain barrier. So we use it to inhibit peripheral enzymes and allow more levodopa to move into the brain. So levodopa conversion to dopamine. Can you see my mouse? Okay. So that carbidopa is going to knock out that dopa decarboxylase. Just allows more of it to get into the brain. And then you all probably talked about it's early on. Early on when we treat with dopamine agonists or levodopa, what we end up doing is the brain, because of what the functionality of those synapses early on, they can store it. They can store the dopamine and then release it. Over time, we lose that. As we lose more and more of those neurons, we lose that function, the ability to store dopamine. And then the person becomes much more dependent on the drug that you're giving them. We'll go over that again. So we have these formulations. We have carbidopa and levodopa that are formulated together. This is one of the most common drugs to start with, Sinemet. And you'll see it's in a 1:4 or 1:10 ratio of carbidopa and levodopa to carbidopa. Usually we start at the lowest dose and we titrate up, mostly because it makes people sick to their stomach. And we want to limit side effects as well. There's also a sustained release. So there's immediate release and sustained release. There's a big difference between them. The sustained release is good in that you don't get these big peaks of dopamine. And what's wrong with that? What happens when what's associated with those peak levels of dopamine?
Dyskinesia.
The dyskinesias. So by smoothing out those peaks with the controlled release, help some folks if they're having those dyskinesias with peak dopamine, then using a sustained release. However, it's only about 70% of the amount of drug you get with the immediate release. So you can start with either one, immediate or controlled release. Most people will start with the immediate release and slowly titrate it up to effect. So you want to use the lowest amount that will control their symptoms. Then we're going to look for where are you having symptoms. And the other thing we're going to look at is how are adverse effects. Then we're going to look at how long does it last you. Okay. So early on, these folks will respond well. Their movements will get better. They will start, they'll become more mobile, and they're going to look normal. They're going to be very fluid when they, one of the videos shows you when they're on and when they're off. So did you all use that terminology?
Yes.
Okay, so what does it mean when they're on? On symptoms.
They're having issues with like their gait, getting kind of stuck up, more shuffling.
Now that's usually off symptoms. So when they're off, so you get these, did you talk about on-off phenomenon?
Yes.
So off is usually when their dopamine levels go down, their ability to their gaits will become impaired. So the longer they go in the disease and the longer they go on therapy, those off periods will become more common and longer. So early on, they're taking the drug every 3 times a day. So they can go from dose to dose and have fluid movements and look pretty normal. The longer they have that disease, the shorter the time that drug will work within that 8-hour period. Did you talk about that? Does that sound familiar? Okay. So what happens is then the symptoms start showing up at the end of the dosing interval. We call those off times. Okay, because they'll become more less able to move. Those bradykinesias will show back up. Okay. The shuffling will show back up. So they may get to the point where they have 1 hour that's good out of that dosing interval. That's when we will start to use other drugs to help, and we'll use it way before that. So that's kind of the difference between those 2 drugs. Either one can start, but most people will start with the immediate release. If you look down at the bottom of page 11, it shows you different dosage forms. Remember I told you the more dosage forms there are, it tells you the more market there is? Okay. So you see immediate tablets. You also see, second is those orally disintegrating tablets. So if let's say that their swallowing is affected. These drugs will disintegrate on the tongue, dissolve on the tongue, and they don't have to use water at all. So that's the advantage there. Cinemet CR we use. Rytary is it's a microbead, and it is formulated to dissolve at different rates. So when it hits the GI tract, it gives a more smooth, slow release of the drug over time. So that helps with people who are having very short responses to the drug during a dosing interval. Okay. So if the symptoms are starting to come back before they're ready for their next dose, sometimes that can help. Did you talk about the intestinal gel? Okay, we'll get to that. Page 12 just shows you the pictures of the different dosage forms. The bottom is kind of a recap of what we've already talked about in terms of using Carbidopa. Look on page 13. I left the verbiage in there because it does a really good job in describing what happens over time to people in terms of taking a drug and then losing effect or the wearing off effect in dosing intervals. So one of the things that they have come up with is a device that you see there, that pump, and you see it has a cassette with it. The cassette holds drug, holds the levodopa. This is referred to as levodopa, carbidopa intestinal gel called Duodopa. So they insert a JPEG into the small intestines, and they give the drug is then given via that pump throughout the day directly into the intestines. Usually they'll receive a bolus in the morning, and then they get a continuous infusion throughout the day. So they've moved to this when people are really having very little effect from the dopamine anymore. So these are usually folks that have had disease for 5 years or more. And when they take an oral agent, they no longer can get good effect during the dosing interval. Or they're having problems with peak effects, and then their off time is prolonged. So this puts the drug directly into the intestine. So the thought is that with the pills, what's happening is that you're having erratic absorption out of the dosage form. That leads to those dyskinesias with peak dopamine, and then the dopamine not lasting long enough because they can no longer store it in those neurons. So they become very dependent on what is the plasma concentration. So early on, they can store it, release dopamine as they need it. Those neurons die off, and so then they are dependent on what you provide them through that drug. So this intestinal gel was developed to get around those problems. So it is a pump they wear throughout the day. I'm not as familiar with what they do with it at night, except from what I've read is that they usually will have them take an oral dose. And so I don't think they wear it through the night. But they can titrate it up, and the ceiling is fairly high, so they've got a high ceiling effect, meaning they can dose it to, or titrate it to effect. Really cool delivery. So did y'all talk about, so that one you didn't talk about, okay. All right. Mostly I want you to be aware of it. The big side effect with this drug is our neuropathies. So keep that in mind. I've given you a video link. If you want to look at someone who and listen to a little bit more about that, that is there. We'll also put down the deep brain stimulation, which you've already talked about. All right. Questions or comments to this point? Okay. So dosing levodopa, again, starting with small doses, titrating up, usually taking with food because it does cause a lot of nausea. Always assessing for tolerance because it will occur. It is expected. Titrating up, usually the average dose is about that 25 per 100 3 times a day. Let's see, on the bottom, the kinetic differences, I alluded to this about the immediate and the sustained release. They are not comparable. And so you're going to have differences if you're switching people from immediate to controlled release. In terms of absorption, usually it requires about a 30% higher dose. So keep that in mind. Next page, page 16. Taking with food. You can, if you are having trouble with nausea, you can also look at giving supplemental carbidopa in addition to what they're taking in the combined products. In the middle of the page, the Parkinsonism Hyperpyrexia. It is really important to talk to the patients and the caregivers about not stopping the drug abruptly, because it can lead to a life-threatening reaction. Is this familiar? I'm seeing some of you are fading. I can't be any more exciting than I am this moment. So it's a life-threatening neurologic emergency. So they get mental status changes, rigidity, fever, and dysautonomia. So that means they cannot regulate their basic metabolic rates. Blood pressure becomes volatile, heart rate becomes volatile. They can't control their temperature, so they can get lethal temperature rises. So this is really important for patients to understand. So not running out of medication, getting the medication on time, especially if they're not able to dose themselves or if they're dependent on caregivers to do that.
Does it go, I mean, if you fix this condition, does it go away?
It is treatable, yes, yes. You've got to get the drug restarted. That's one of the part of the treatment is get them back on the drug dose they were on. Some could be treated, mild could be treated outpatient. Some people would need to be admitted and maybe even to the intensive care for treatment and support. So a lot of it is until you can get the drug restarted, is supporting the body until you can get enough dopamine back in them. Adverse effects, these drugs do cause a lot of adverse effects. The nausea we talked about, dizziness, somnolence. Orthostatic hypotension is very common. If anybody ever asks you what's a common cause, always say dopamine, dopa, levodopa. Very common orthostatic hypotension. So what is orthostatic hypotension? So it's a change in position that leads to a blood pressure drop that they can't maintain perfusion. So they may lose consciousness, fall, hurt themselves. Okay. All right. So motor complications, there's a video that gives you really good examples of that I'd refer you to. So you've got the motor fluctuations, you have the wearing off phenomenon. So that's where they just don't have enough dopamine to sustain motor function, so that you get that wearing off or that off period. Involuntary movements, again, with peak dopamine, that's those dyskinesias. Motor complications are higher in younger onset. So the younger patients will tend to have more difficulty with that in the higher doses. Page 17, the chart at the top kind of is just a summary of what is in the text below it. So end of dose wearing off phenomenons. There is increasing the dose, something that will get more levodopa into the brain. You could also add those inhibitors, so adding those MAOBs or the COMT inhibitors would be an indication for that. Some patients note that if they take drug with food, that it delays their response or their effect. So often that nausea will wear off over time. They won't be as nauseated once they get accustomed to the drug. So then you can switch them to take it on an empty stomach. So a lot of times this will be most prevalent in the morning when they've gone without drug overnight. You could also use apomorphine. We're going to talk about it in a little bit more depth. Did you all discuss that? They talk about using it as a rescue or an intermittent subcutaneous apomorphine? Okay. It's called freezing or start hesitation. They just get stuck. They get really frozen in their ability to move or to initiate movement. So this is, again, increasing the dose. You need more dopamine in the brain. So adding a dopamine agonist, using those inhibitors is also. Another thing that is very helpful is to have them work with a physical therapist. There are rhythmic and gait cues that they could use. I'm going to show you a video of that using music. It's really impressive. Did they show that to you already? Okay. Let's see. All right, let's. So dystonias can occur with peak effects of dopamine, but they can also occur during off periods. On the next page at the top, you see those toes clenching. That is an off-time dystonia. So That's a common where they get the toes that clench. Can be really painful for them. Usually happens early in the morning before they get there. They restart the drug. Using apomorphine in this, which is a dopamine agonist, can also help during that time. Okay, let's talk about the dopamine agonist. Let's see. There's quite a few of them on the market. There's Parladil, very old drugs, been around forever. Mirapex, Requip, and Nupro are much more newer products that are now on the market. And then injectable apomorphine. Again, that one is used more as a rescue. Think of it as rescue, intermittent, when patients have critical responses that, or dystonias that need to be treated. They're direct agonist, can be used for monotherapy. Y'all have already talked about it. You can start people on these, particularly the younger patients. Placement therapy, it is not as effective as levodopa, carbidopa. Patients cannot be left on it forever. They just won't respond over time. Can be added to levodopa to reduce off times. So like breakthrough. Think of it as a kind of a breakthrough medicine. Next page, more expensive, more side effects. Lower risk of dyskinesias, wearing off and on-off fluctuations than what you see with the levodopa, carbidopa. Higher risk of hallucinations. May impair impulse control. So this is where the gambling, the hypersexuality, the spending money can become a problem. Excessive daytime sleepiness. So this is why it's hard to use in the older patients, why they like to start with the levodopa, carbidopa. Younger patients a little bit more tolerant. Dosing at the bottom, at least 3 times a day. So it's like carbidopa, levodopa. It's a 3 times a day treatment. There is a patch though, which is a daily, that Nupro, which may be helpful for some patients who have adherence problems. The apomorphine, just a little bit about it. We talked about it's very short duration. It's used for acute treatment, intermittent rescue. Next page, page 20. It really makes them sick to their stomach. So it's recommended that you pre-treat them with, in the United States, they recommend trimethophentamide as a prevention. Do not use ondansetron. Don't use the serotonin agents because it can drop their blood pressure too much. So it's recommended that you have some type of challenge dose to see the effects on the blood pressure. So if you've got people who are older and are on blood pressure medicine, those are probably going to be the ones that are be much more critical. Other label warnings that you should take note of are that QT prolongation. It's another problem in using with an ondansetron. Hallucination, psychosis. It's a big dose in a short period of time, so you can see why the hallucinations can be a problem. The psychogenic side effects, sleepiness. Next bullet, don't stop these abruptly. Just like we talked about levodopa, carbidopa, don't stop the dopamine agonists. You can get the same kind of problem, the neuroleptic malignant syndrome. Same symptoms, same problems that we talked about with levodopa. Common side effects, again, nausea, orthostatic hypotension. Do not forget that one, mark it. I'm sure it will come up in a test question. Very sedating. So if patients are still able to drive and are driving, so your younger patients, you want to warn them about the effects on sleepiness and operating machinery, because they can have sudden going to sleep. Dopamine agonist withdrawal can resemble cocaine withdrawal. So you can imagine in younger patients that this could look like a drug reaction. keeping that in mind, even having them wear some type of medical alert, especially if they're young. You know, if they're older, that's one thing. But if you've got somebody who's in their 30s, 40s, early 50s, so drug use might be suspected, I think that using a medical alert would be really important. Questions about the dopamine agonist or the levodopa? Okay. Cornerstone of therapy. Body is very dependent on the ability for you to supply it dopamine and store it, or to continuously supply it. So how you dose it is going to be dependent on how well it controls symptoms and what kind of side effects it produces. Okay. So the dopamine agonists, younger patients, older patients, start them on the levodopa. Okay. The next one's the Mao B inhibitors. Remember we talked about MOA inhibitors? So these drugs are usually selective. So there's monoamine oxidase A enzymes and B enzymes. These drugs, just kind of like we did with beta blockers, they are selective for B at low doses. Usually at higher doses, then they may also inhibit A as well. What do you remember about those enzymes? Anything? We haven't had depression yet, so we haven't talked about them as antidepressants. What are we always saying? Don't use within 2 weeks of someone taking an MAOI inhibitor. Okay. So why is that? Get too much what?
What it's supposed to be.
Well done. Very good. Very good. What do they usually? What do these enzymes? Serotonin. Mostly the catecholamines. And then also dopamine. So most of the neurotransmitters are terminated either through reuptake. What's that mean? Sucks it back up. Okay. So you got an impulse coming down a neuron, gets to that presynaptic. The vesicles move to the membrane, release it out into the synaptic cleft. What happens to it? Some of it goes over to postsynaptic, right? Does what? Combines with what? Receptors. Transmission goes on. The stuff that's left over, what happens? You can retake it up back into the presynaptic vessel. That's reuptake. We have drugs that will inhibit that and leave the drug around longer, or we can destroy it with these enzymes, right? Okay. So you got COMT, catecholamine methyltransferase, and then you've got the MAOAs and Bs. Okay. All right. So what happens if you eat cheese and you're taking an MAOI inhibitor? What? Okay. So there are dietary restrictions when you are on these drugs because they, especially drugs that have tyramine in them, alcohols, fava beans. Those are ones I can think of off the top of cheeses, okay, because they can really impact their blood pressure. So with these drugs at lower doses, dietary restrictions usually aren't a problem. If you're using higher end, and then sometimes you will have to put them on dietary restrictions as well. Okay, so there's 3 of these MAO B inhibitors. There's selegiline, the oldest of those, rasagiline, and then sulfonamide, which is a new one. The 2 older ones are irreversible inhibitors. The newest one is a reversible inhibitor. The 2 that are preferred are the older because there's more experience with them, so they're usually the go-tos. These will increase on time. So on time means you got enough dopamine, your motor neurons can function, you can move around, your dyskinesias go down, your ability to talk, show emotion on your face, all of those are what you want on your on time. So they're going to decrease off time. These can be used early on by themselves. I would say it would be unusual, or it's going to be a limited number of people, but it is possible to use them very early on. Later in disease progression, they would be added to. They're going to be adjuncts to dopamine agonists or levodopa. Selegiline, the one thing to remember about it is they call it activating, which means that it kind of revs you up. It gets converted into an amphetamine. Keep that one in mind, because it could cause side effects in some people. So that's selegiline. So insomnia, hallucinations, jitteriness, not wanting to eat, killing off your appetite, wanting to move around all the time. Selegiline increases peak effect of L-DOPA, so the dyskinesias, the on dyskinesias, can be worsened. Let's see. A couple of bullets down is where it talks about low dose selegiline doesn't have dietary restrictions, higher dose would have it. Last bullet, care must be taken when starting or stopping selegiline to avoid precipitating a hypertensive reaction or serotonin syndrome. Rasagiline, let's see if let me look at things. It doesn't have the amphetamine activity, so it doesn't get converted to amphetamine, so that would be a benefit in someone who's having trouble with selegiline. Okay, look at the last one. Note, when adding it to levodopa therapy, a dose reduction of levodopa may be required. Okay, so think higher peak dopamine, dyskinesias. Under the very end, general information for the class may cause hallucinations, because you're increasing the amount of dopamine available. Nausea, insomnia, lots of drug interactions. Next page gives you kind of a picture that shows as you inhibit MAOB, your dopamine levels go up. It's just a visual. Anticholinergics have a limited role in Parkinsonism. So the tremors can come about because you've got elevated cholinergic activity because you have an imbalance now in neurotransmitters. So as the dopamine goes down, those cholinergic fibers can become more active. So sometimes the initial presenting symptom are tremors. So it's a rusting tremor. So if that is the major and you're dealing with a younger patient, then you could consider these as first-line monotherapy. You would not want to use it in someone who's cognitively impaired, so your older patients are going to probably not be a usual drug you would use in them. Cognitively impaired, demented, you're not going to use this drug in those folks. So the same kind of side effects we've always talked about. What are the side effects of the anticholinergics? Anti-SLUD, salivation, lacrimation, urination, defecation. Anti-that. Amantadine is usually an add-on. It's rare that you would use it as a solo agent. It does say that you could use it in younger patients to target a tremor, but it's very modest in its effect. It would be an add-on to dopamine therapy for if they're having a lot of bradykinesias that aren't being controlled by other method. You go down to the COMT inhibitors. There's two on the market. There's entacapone, which actually comes in a combined product with levodopa, carbidopa. And then there's tolcapone, which is an older agent. The problem with it is that it has a significant risk of hepatotoxicity associated with it, whereas entacapone does not. Think of them as levodopa extenders. So they're just like the MAO inhibitors. They're going to increase the amount of time that dopamine is around. So always adjunct. Don't use them as monotherapy. There's no indication for them in that regard. The biggest thing at the bottom, adverse effects, is the same as with any time you increase dopamine. Those same side effects are going to show up and they're listed there. The bigger is diarrhea that will not go away, and the hepatotoxicity. Keep that in mind with that task mark. The other with entacapone is orange urine. So another color to add. Has not been associated with hepatotoxicity, so it's more the go-to. Estrogen therapy. So there's been a lot of look at women who stay on estrogen postmenopausal. Is there a benefit to preventing or decreasing the risk of Parkinsonism? So it's recommended that these would be adjuncts. So using a low-dose estrogen in women who had no contraindication to it may be of some benefit. And it's listed down there under the second bullet as it may improve on time or motor control in those women. Okay, anything that I told you that goes contrary to what you were told? I would say the big things that I'm going to concentrate on are side effects and effects of the drug. Because what you use, now, if you look on the last 2 pages, I know you all have been talking about evidence-based medicine. So there's the International Parkinson and Movement Disorder Society puts out a guideline. I don't think I posted it, but I can if you're interested. But what they had at the end of their guidelines from this year is they listed the evidence-based progression of medicines for early and for late Parkinsonism. More, I put it there so you can see how you start. You're always going to start with levodopa or dopamine. What you add after that is more going to depend on the patient's symptoms and how long they're getting effect. But I wanted to at least show you what people are looking at in terms of neuroprotective and what to add at different stages of Parkinson's. So I'm not going to test you for this, but I wanted you to see the flow. There are a lot of interest in drugs that are herbal and over-the-counter. I can tell you that none of them have demonstrated effect, but there's a lot of it out there in that community. Creatine is one of them, vitamin D is one of them, and CoQ10 is another one of them.
Velvet bean, right?
Pardon?
Velvet bean? Velvet bean has L-dopa.
I don't know that one.
Really?
What is that?
It has L-dopa in it.
Oh, really?
Yeah. So people extract it.
Really? I haven't
Get a
seen
certain
that.
percentage of L-dopa in it.
Yeah.
I can't remember the scientific name. But
Do people use it for hallucinogenic properties?
I don't know. I just heard people using it for this.
For
or
this?
like that. Yeah.
I have one video I want to show you. So I told you about rhythmic and gait cues that can be used to help people with Brady dyskinesias. This is a video that shows you dance therapy. I've also included a video that I gave you that is on exercise. Exercise is really important. There is something about using different parts of the brain and being able to help people have more fluid movements. It's impressive. Watch them the exercise. The last one is a TED Talk. It is so inspiring. It's a guy who's brilliant, not Parkinsonism. And in the end, he talks about how dance therapy helped him, and his dance partner comes out and he dances. It's just, it'll make you cry. But I do want you to see this. is 3 minutes.
Cool little study I came across. It's actually been out for quite a while, but